Good morning. I deeply appreciate your patience this morning when I had to give my speech without the advantage of the PowerPoint. The advantage of the PowerPoint in my case is because of my strong accent and images certainly ease the pain of those who have listened to me. What I want to be absolutely clear, and I don't have a PowerPoint image for that, is my admiration for the American Society Syringomyelia and Chiari Alliance Project, the ASAP. You are a remarkable group. You allow physicians to sit at the same table with the patients, an honor that we physicians deeply appreciate. And you allow the conversation, discussion, and you also allow individuals like me, this is my fourth time, that speak of the other aspects related to Chiari malformation. I am not in clinical practice. In the last 7 years I became an emeritus, which is the nice word for retired, and I've been focused in one issue related to Chiari, which is exactly what is Chiari and how we understand Chiari. The title of my talk, the how meets why meets who. The who is us, the healthcare workers, or the patients interested in understanding what Chiari is beyond the current understanding of an image of the tonsils and a set of symptoms. So the who is you, the patients, curious patients, and us, the healthcare workers. We all face a phenomenon, in this case Chiari, but the phenomenon could be any other event that calls our attention. And about a phenomenon, we all humans have an opinion. Let's stick to the idea of the Chiari in the sense, okay, an individual comes to your clinic, or one of your friends asks you a question, and then we all say, or you say, okay, the tonsils are descended, there's neck pain and tingling in the hands, in the upper extremities, tingling in the upper extremities, that's Chiari. So we have an opinion. But the next step, in order to make it really substantial, is to come with a how and a why. How and why are connected concepts, no? Okay, I have these cerebral tonsils that are descended, but how is that affects my third and fourth cranial nerve? I have diplopia. Or how is that I have retroocular pain? Okay, can you explain retroocular pain by the stretching of the dura mater and the tentorium and the branches of the trigeminal nerve? But why third and fourth nerve, and why not lower cranial motor symptoms? Why upper cranial motor symptoms, brainstem symptoms, or lower or upper? And why my MRI is identical to this other individual, but nonetheless the set of symptoms that the other individual has are completely different? And here is where the explanation of the who are you and are us. But I will talk about us because this is what I know, our biases. No, I don't know, and I don't pretend to know the understanding of the disease and the feelings about the disease that the patients have, the experience of the patients. The physicians, or the healthcare workers, or the scientists, neuroscientists, neurologists, neurosurgeons, nurses, physiotherapists, we have a concept about Chiari, but the concepts are not spontaneously created, are determined by their ancestors. One of the most commonly studied cases in the history and philosophy of sciences is that the Semmelweis, the Hungarian obstetrician working in Vienna, who pushed for washing the hands in order to prevent puerperal fever. But the concept and the creation of Semmelweis of that concept was a series of trial and error, and finally got the right steps to prevent puerperal infection. But the interesting thing is that when he was comparing the rate of infection, the infection rate between two wards, Ward 1 and Ward 2. Ward 1 had a very high infection rate, Ward 2 had a lower infection rate. Still, patients suffered in Ward 2, but obvious difference between both wards. And he compared, he looked at the priest, whether he worked first by Ward 1, he looked at the position of the patients, whether they deliver supine or lateral decubitus. He looked at all the other differences between the presence of students in Ward 1, and they were imitating in Ward 1 all the practices in Ward 2 by no avail. There was no difference. At the end, the infection rate remained the same. Then one of his friends, Dr. Koletstra, contracted the disease, contracted the puerperal fever. So a man who was not pregnant had the same set of diseases, a set of symptoms that the ladies who suffer from the condition. And what Koletstra has been doing before is he was involved in an autopsy and he cut his finger and he developed. So Semmelweis says, I understand there is something in the cadaver and we need to wash our hands after doing the autopsy. And they did that and the infection rate decreased, but then jumped back again. And jumped back again because they washed their hands between the autopsy and the first patient. But they didn't wash their hands between the second patient and the third, and successively that. And it was enough that one of those patients in the series that were being examined had already puerperal fever, that the disease will be transmitted to the other ones. And then so Semmelweis said, okay, let's wash our hands even between after every patient, after the autopsy, before the first patient, and in between till the last patient. Why I mention this? There was one obvious difference between Ward 1 and Ward 2. I mentioned the priest, that first for Ward 1, mentioned the position of the delivery, mentioned the students, everything. The big difference was that the Ward 1 was staffed by physicians. Ward 2 was staffed by midwives, not by physicians. And that is an obvious phenomenon, the obvious difference. Forget about the autopsy, forget about the other things. But they, Semmelweis and his colleagues, didn't see the obvious. Paraphrasing a past president, are the physicians stupid? But the WHO, the idea that the physician could be contaminating patients did not permeate into the body of physicians. And this, by 1840, so 20 or 30 years before that, Oliver Wendell Holmes, the American doctor, the father of the Supreme Court Justice, he already noticed that, but he published that in a New England journal, but not the New England Journal of Medicine, but in a journal in New England, scarcely read. And he was chastised by the community, and he was chastised by very prestigious doctors, among them Dr. Knight, the founder of American Obstetrics Science, precisely stating that we physicians do not contaminate patients. Why I am telling this is saying that the prevailing idea on a time affects the way that we address, understand, and study diseases. It always puzzles me when I look at Chiari that we do decompressive surgery. You read the papers, those papers that justify a procedure. The only justification that you find in papers that bother to explain that is decompression. We are doing this to decompress. So from where the idea of decompression started, so I started looking, tracing back. And although I came with the first paper by Bussi, there is a paper prior to Bussi by Penfield, one of the giants of neurosurgery. And in this paper, Annual Chiari Malformation and its Operative Treatment, he tells the story of a 29-year-old librarian who had a series of cranial nerve pulses, and she had a set of cranial nerves, as I said. One particularly bothered her that she lost her position as a bookkeeper because tears that she could not wink away fell on her work. The librarian that winked, or the librarian that couldn't wink. So they do a surgical procedure with a diagnosis, a presumptive diagnosis of a posterior fossa tumor, bilateral neurinoma. They open, they explore, they don't find the tumor. They do the occipital craniectomy, Y-shaped genomater incision. They found a collection of fluid on top of the cerebellum, between the tentorium and the cerebellum. And then Penfield remembers that this patient has had a operation for a meningocele, an upper thoracic meningocele, when she was 2. That's the image on the slide, and the drawing from that paper, the anatomical drawing. And then he attributes that the descent of the tonsils and the appearance of the nerves and the symptoms to the traction exerted by the tether cord. And this concept has been renewed by different physicians, prestigious doctors, prestigious scholars who perform untethering of the cord in some patients who have a Chiari. But the how and the why, so Penfield was puzzled by this phenomenon. He was having not a classical Chiari patient. A classical Chiari patient until then was a child or a young adult with a myelomeningocele. This was something different. Yes, she had a neurotube defect, a meningocele. But even if it was noticed before surgery, they didn't pay attention. It wasn't like a classical myelomeningocele. It was something different. And even he says that if he would have thought of that, they would not have done a suboccipital craniectomy. Because when he opened, he found the key word was traction. As you can see, traction was observed, effect of the operation, relief from traction on the cerebellum. So he had the concept that the problems, the how and the why, was traction. And he based this concept in the papers he had read before. So what we said in previous images, concepts are not spontaneously created, but are determined by their ancestors. So we move some years forwards, and we come to the paper by Paul Busey and Lingenstein, Arnold Chiari deformity on an adult without obvious cause. So we have one at the patient that was not the typical Chiari that Chiari, Adams, and even somehow painful treated. We had somebody who did not have any remote relation to spina bifida or neurotube defects, didn't have any remote relation to hydrocephalus or any forms of intracranial pressure, classical forms of intracranial pressure at the time. As the patient had a series of symptoms of upper, middle, and lower brainstem, a brainstem flurry of symptoms, and had a myelogram that shows obstruction in the medulla, they also thought a medullary tumor. They went, they explored, they opened C1, they opened the dura, they searched for the tumor, they didn't find the tumor, but they found that the tonsils were descended. So in that paper, Busey says the paralysis, sensory disturbances, and complete subarachnoid block resulted from pressure of this deformity on the unyielding bony rim of the foramen magnum. Yes, here we have the first time the word pressure of the posterior fossa is linked to the idea of Chiari. We have pressure. And this is the image of from Busey papers, and this is an image from a patient in my hospital back from the mid-90s. So you see the similarity. I don't need to stress on that. But we idea that we are doing pressure and we are decompressing. As Busey was looking for a posterior fossa tumor that he couldn't find, or anywhere a medullary tumor or some form of tumor that he couldn't find, he made a big incision. But still he attributed the problem, the symptoms, to the pressure, which is traction is a visual metaphor, a visual idea. You see something is being pulled. But pressure is not that. It's not that clear as it is traction. But we created this idea of pressure. And incidentally, confirmation that there is a pressure in the posterior fossa in patients with Chiari has been seen in patients who have Syringomyelia, and that is the foundation for the treatment of Syringomyelia, the relief of the pressure. But it's not clear what pressure is in pure Chiaris or Chiaris without Syringomyelia, and of course without hydrocephalus. And that issue would not have been that relevant after all if it would not be for the availability of the MRI. You can see there again the number of papers up to the 2000, the number of papers and publications about Chiari increased almost exponentially because Chiari patients were more frequently seen by physicians who start pondering and reporting and the different alternative treatments. And as such, we had, so as I was saying, there was a flurry of cases, and that led that we start seeing a large number of patients with descent of the cerebral tonsils, with the anatomical or radiological description of Chiari, but still with a flurry, with a whole gamut of symptoms, different symptoms. And we could not work on or associate clearly the severity or the nature of the symptoms just by looking at the image. The patient, the second image on the left, has a occipital pain, retroocular pain, paresthesia, And the last image to the right, with a descent of the tonsils with a almost vertical tentorium parallel to the clivus, even some minor perhaps dilatation of the lateral ventricles and squeezing of the brainstem, is an incidental finding. So that begs the question of what exactly are we looking at? And again, I want to say, I mean, I've done many Chiari. I had the privilege of treating many Chiari patients, and I did in all the patients different degrees of decompression. I was an adherent, and I am still until proven otherwise, an adherent of the theory that we may have some pressure there. But perhaps is it time to look backwards retrospectively and start reconsidering what we understand as Chiari. Not challenging at all the treatment, not challenging at all any of the treatment alternatives. I am just asking, what do we understand by pressure? Because different surgeons have different methods. I have seen patients in whom the dura was just slit open and or suboccipital craniotomy, slit open of the dura, C1 laminectomy sometimes, and that's it. And the patient did marvelously well. And I have seen patients that know that they had dura opening, arachnoid opening, tonsillar cauterotomy or tonsillectomy, and they did as well as the other ones. And also I have seen patients in which, and some of my patients in which I was limited in the surgical access and had to go back again and be more aggressive, for lack of a better word, be more thorough in the decompression process. So why one patient did very well with this surgery and the other one did not as well, and the images were similar, but the symptoms were different, or the predominance of some symptoms over others were different. But we, as I, and I presume many of my colleagues, we still are ensnared and mesmerized by this concept of an anatomical structure improving and making a huge difference on the rest. Claude Bernard said that anatomy never resolves a physiological question. And we have not addressed yet the physiological question of Chiari. But maybe it's time to start rethinking the name of Chiari. I do remember a conference here in Chicago, and I say here, this Zoom or digital platform allows us to be, all of us in Chicago, from our own houses or places of work, that this colleague in Chicago, and I don't remember his name, he said, perhaps we need to forget about Chiari. We need to reshape the understanding. And that is not criticizing the treatment. If you have a Chiari surgery scheduled for this week, do it, because it is successful. It is working. The only thing I say is that it's working, but let's try to understand. Let's try to really finesse the how and the why of the circumstances. Semmelweis, going back to Semmelweis, he came with the concept of washing the hands after seeing every patient. Yes, fantastic, but he thought that was because of the cadaveric system. Well, it's not the washing the hands that prevents the the propagation of the disease is not having the bacteria in any instrument or something that goes in contact or contacts the patient. So you may not wash your hands when examining patients and nobody is infected because nobody was infected before, and the first patient that the doctor examined and didn't change his gloves or her gloves didn't get contaminated with the streptococcus. And the same on the other hand, you may wash your hands but not wash it thoroughly, and you still have bacteria contaminated. You will contaminate. So the issue is not washing the hands. The issue is something further, and that's what I'm saying. Chiari surgeries are extremely successful. Nobody denies that. But that we still have a conference about Chiari every year, and we still publish papers about Chiari, is because we have not really found the key to the keyhole that Chiari says. And perhaps we need to forget about Chiari, just keep it the name of the society. But that is difficult. That is an uphill battle. Ludwig Fleck said that when a conception permeates a thought collective strong enough so it penetrates as far as everyday life and idiom and has become a viewpoint in the literal sense of the world, any contradiction appears unthinkable and unimaginable. And this is the who. We, the neuro healthcare workers, still have a concept of localization. We localize things. This is the area of the speech area, this is the area of other, this is the third area, the fourth area. And we go to the classical anatomy textbooks now, and then we find speech area, this, Wernicke and Broca. But surgical procedures with patients awake, when they map the cerebral cortex to find the speech area, see that the speech area is everywhere. Everywhere in the cerebrum, between the frontal, temporal, and parietal lobes. Luria, a Russian psychologist, said that the Broca's area, the structure of Broca's area impairs the speech. Doesn't mean that the speech center is in the Broca's area. Well, it's not in the Broca's area, but on Wernicke. What I mean is that we, the neuroscientists, the neurosurgeons, and the physiatrists, and the people who work, address this issue with the Chiari, we still are, and I say we, myself including that we, trapped by the idea of localization. We still have not looked at a dynamic way that will make us understand maybe many other things about the brain, but why a cerebellar tonsil descended affects the third and fourth nerve up, or affects the third and fourth and the 10th and the 11th, but in this patient, but not in this other patient. Again, I want to repeat my immense gratitude and admiration for the society, and I thank you, thank you, thank you.